Next, I'd love to introduce Sara Seegmiller, who is our next presenter, who will be speaking on choosing the right tube. Sara, thank you for joining us today.
Hi, thank you for having me. As Andrea said, my name is Sara. I'm one of the tube nurses, as we call ourselves, here at Mayo Clinic Rochester. I actually work in the home enteral nutrition clinic. Just a quick, brief background that I am a nurse. I have my 4-year, graduate my 2-year, then my 4-year. Currently, I am finished my classes, but I'm trying to finish up my thesis so I can have my master's. I spent my first part of my career at Olmsted Medical Center, a smaller hospital here in Rochester. Worked there for about 13 years in the ER. Then came to Mayo in 2008 and started in GI. GI here at Rochester Mayo back in that day placed the vast majority of our tubes here in Rochester. So I quickly worked my way up to being one of the 2 nurses to place tubes. PEG tubes, PEG tubes. So I placed tubes for about 6 years, and then I became part of the home enteral nutrition team in 2013. And right now, our HEN team works with patients who have tubes placed in GI and interventional radiology and in surgery. So before I start with the tubes, our clinic here, there's been a couple of questions that I got earlier about what kind of education somebody should get and what's out there. When I say home enteral nutrition clinic here or the HEN clinic, we'll talk about somebody getting a PEG tube, just as an example. If somebody were to get a PEG tube as an outpatient adult here at Mayo, they would come to the HEN clinic first. They would actually see a dietitian, get kind of a background. Dietitian would get kind of a nutritional assessment background, what their norms are for eating and drinking, fluid intake, weight over the last couple of years, that sort of thing. Then they would talk about how the patient's going to tube feed, what supplies they'll need, what their insurance will cover. Then the nurse sees next, and we go over the type of tube that they're going to get, depending on what area is placing the tube, how to take care of the tube, basics of if it's a balloon tube, what to do if it falls out. So we got to go over education of the tube and how to care for the tube and site afterwards. Then we actually have a nurse practitioner that sees the patient. They give the final say. They kind of do an overall assessment, maybe monitor labs, just make sure we're on the right track for that patient. Then they go get the procedure either same day or the next day, and then they actually come back to see the same team the day after procedure, just the nurse and dietitian. As the nurse, we go over and do the site care on the tube, and then we have the patient do the site care. Then the dietitian will see, and they'll actually go through the feeding, start a feeding, have the patient do a feeding, hopefully so that by the time they leave us, they feel like they've touched the tube, touched the feeding, and kind of get that general background or general knowledge of how to work with the tube. We see on annual about 1,200 patients a year. So we do a lot of education on these tubes. So we'll start off with the basic PEG tube. PEG tubes, G tubes, all go into the stomach. The PEG tube, the reason we use that word PEG is because it's endoscopically placed. So these are the ones that are placed usually in an upper endoscopy type procedure in a GI area. They could also be done in surgery. Could be a bumper or a balloon tube, but they're all placed via the endoscope. They can also be placed for venting. Some use the tube as more of a decompression tube. With that being said, the G tube, and we do refer to them interchangeably, and they get used interchangeably in literature and different facilities, but a G tube here for us is a tube placed in interventional radiology. So the tube is placed by them putting a nasal tube down to inflate a little air into the stomach, and then the tube being placed, no endoscope involved. So nothing actually goes down the throat except that for a French nasal tube. So these are done in interventional radiology. They could also be placed in surgery. Because of the way they're placed, they're only balloon tubes. Again, going into the stomach, and could also be placed for venting. So I actually, since I'm at work today, I'm able to show you what I mean by those two different types of tubes. So I have kind of the picture here going into the stomach. So again, with the GI one, they would actually take the endoscope and go down the esophagus into the stomach and then actually pull the tube through. Then we attach everything, have a bumper on the inside, the rest of the tubing on the outside. With that balloon tube in GI, they would still have the endoscope down, but they would actually create the hole or the stoma from the outside and then slide a balloon tube through. That's exactly the way that IR places a G tube, except there's again no endoscope. So they actually under X-ray find a spot, create a stoma or the hole, the tract, and then place a balloon tube through. So I have pictures of both the tubes. However, what I can actually show you the actual real tube, if you will, versus just a picture. There's the bumper tube again, like we kind of said, that is the one that GI places or would have to be placed in surgery. You have to have an endoscope to place this type of tube. That bumper is actually very pliable. And so when it gets pulled through the esophagus, it does actually just kind of constrict down and slide down the rest of the tube or down the esophagus. Then we place the skin disc and the external end adapter. So it's just a tube that goes through and then that bumper that deflates. The balloon tube, as shown there, is the one that could be placed pretty much anywhere, GI, radiology, and or surgery. So same principle, it's just when that balloon gets inflated, we can actually inflate it to minimal or to the full balloon amount that can be put in the tube or in the balloon. Most balloons, I shouldn't say that. Some balloons are 3 to 5 mils and others are 7 to 10. Really just depends on what area of your body they are being placed in. So not a lot of other areas place what we actually call PEJ tubes. Again, we use the word PEJ because that E is in there for the endoscopic part of it. So a PEJ tube, again, is placed in GI. It's done via the endoscopic procedure. So here at Mayo, we actually have a set specialized team in GI that uses what we call here either a single balloon scope or a double balloon scope to place these down into the jejunum. They only place bumper tubes, and this gives us the ability to feed into the jejunum. There's a couple one-offs there. We've done it into the cecum to be able to allow people to administer like laxatives to help clean them out if they've got a very slow motility. That's pretty few and far between, but the PEJ tube here, we actually place quite a few because GI has that special team that can do it. Otherwise, a J tube, again, no endoscopy done, is generally the one that people hear about more, and that's the one that's more placed like in surgery. Interventional radiology here at Mayo does not place new J tubes. They will replace them, but the actual placement of those types of tubes are placed in surgery here. Generally, if it's one of our surgeons placing it, is a locking loop catheter, or if one of our GI, or they could do a balloon. Again, in GI, it's only the bumper because they're pulling that through. Then again, we're feeding into the jejunum. So again, same tubes I just showed you. That bumper tube is the one that GI uses and pulls down through. The retention balloon, or the one with the internal retention balloon, is the one that surgery may place. Or I have a picture there of the locking loop, but Actually, this is the one that our surgeons tend to use. When they create the tract into the jejunum, this actually goes in all straight, and then there is a suture material wire through the tube. When the surgeon is happy with where the tube is placed in the jejunum and the tract, then they will pull on the string, creating that loop at the end of the tube, and then that is usually about what's left inside a jejunal tract. And then for us to be able to connect it with infit, we have to add several pieces to it. This type of tube is generally stitched to the skin. Otherwise, any of our other tubes don't get stitched because there isn't any reason, because they have that balloon or the bumper, and then they have the skin disc on the outside. This type of tube doesn't have any sort of skin disc. We actually see these quite frequently with our surgical patients. So again, the only way the surgery one is different is they generally do much more of a tunnel tract, because generally if they've had surgery here, they're usually removing either the stomach and pancreas. So the anatomy is changing quite a bit. And so at the very end of that surgery, they will create a deeper tract into the jejunum and feed. But technically, you could feed anywhere in the area of the jejunum. It's really just being able to find the right spot to be able to access. Transgastric jejunostomy tubes can be placed in either GI or radiology. These are the tubes that allow patients to be able to eat or feed and vent also. So a lot of times we will start with a tube like this in GI, or we might start with a PEG tube, and somebody just doesn't do well feeding into the stomach, and so we may try to switch them to a TGJ. Let's keep the same stoma, so we're not creating a new hole. However, we're inserting the TGJ tube in through that stoma and then pulling the jejunal extension down into the jejunum and actually feeding there. So feeding into a different area, but maintaining that gastric stomach stoma. Sometimes they're placed right off the bat. They're felt to be easier to place a lot of times than the jejunal tube. Again, if somebody has to vent, a lot of times it's easier to place this tube and allow the tube to do both instead of placing a tube in the stomach to vent and a tube in the jejunum to feed. Two ways to place these tubes, or two types of tubes, I should say. The figure 3 is a dedicated PEG tube, so that bumper tube again that can be used in the stomach or jejunum is placed first. So we create that stoma in the stomach. Then what happens is GI tends to cut the tubing, and they place a jejunal extension down through the actual PEG tube. So we've got the tube is sitting in the stomach, and then that extension piece goes down into the jejunum. So it's kind of what we call our modified tube. Again, allows for both. We can vent out of one port and we can feed in the other port into the stomach or into the jejunum. And then I do actually have a TGJ tube here, which is kind of nice to see. So that is a one-piece tube.
Sarah, we unfortunately lost your video feed. Your audio is fine, and your slides are too, but we can't see you. Oh, there we go. There you go.
Okay. I don't know what that was.
Yeah.
Sorry about that. So the actual TGJ tube is nice because it's a one-piece tube. Again, it has the extension piece, so it's going to go into the stomach just like a PEG tube or a G tube would, but then the jejunal piece would actually be pulled down into the jejunum by an endoscope, or in radiology they just do it under X-ray. But there are several holes in the end of the jejunal tube to allow the feeding to come. Then sitting in the stomach is a completely different part of the tube, because underneath where the balloon would sit is a couple holes again to be able to vent. So you can actually vent the stomach, feed in the jejunum at the same time. We're in two different GI areas, if you will. And so on those tubes, they're actually dedicated for this. So one of the end adapters will say gastric, meaning stomach. So that's the venting one. And then there will be one for feeding, and it will say jejunum. And then we have our balloon port. So either one, they both work the same. Just really depends on what kind of the purpose is, and how long term we think it's going to be. So there's kind of a picture of that tube again going into the stomach. So our only hole or stoma is going right into the stomach. And then that extension piece is going down into the jejunum. So again, right there, we're kind of feeding, everybody's a little bit different when they get their gastric stoma placed or the PEG tube. And so the ending point is kind of different for everybody. Just again, saying that we can really feed anywhere in that jejunum, and hopefully get the same benefit. Low profile tubes are one that we get asked about quite frequently because people don't want the dangler or the tubing on the outside. Here at Mayo, we do have a couple recommendations that we like to hit first before we will use a low profile tube. So the other part here at Mayo is we do not place low profile tubes right off the bat in any adults in radiology or GI. Reason being is that most of our patients are getting that tube because they can't maintain their weight or they've lost weight. With a low profile tube, you cannot adjust the skin disc. There is no skin disc. You can't adjust and make up any differences for weight gain, weight loss. And so we do not, and have not since I've worked with tubes, ever placed them in adults. So we'll place one of the other tubes. And then when we do the replacement, if a patient is maintaining a stable weight, we do actually also make sure that a patient can hook into hook up a low profile tube, the adapter, and then just make sure that the size is okay. The companies only make so long of tubes. They've got many different sizes, so usually that's not a problem, unless somebody's really like at a 6-7 centimeter mark or has a really long tract. So some of our surgical J's, low profiles are really never an option later on because their tract is so long. So low profile tubes also can be used for venting. We've got patients that have good success with them, and then we have other patients that say, take it out, put me back to the dangler. It doesn't work to vent. Reason being is that the tube, and I'll show you here. There we go. The low profile tube is shown there. And again, I can show an example of one here. Tubing is still the same size. So if you have a 20 French, if you have an 18 French tube, that all stays the same. So venting that way doesn't change. What changes is when you hook up to vent, you are hooking up to vent through that hole. So with a low profile tube, you actually have to attach an adapter and feed. And again, this tubing is great. It's that it has to come through that little hole there and go into this tube in the same area. And again, the tubing on both ends is great. It's that match-up point that's very small. Some people can still vent great. They can hook up and vent. We will say, go ahead and try it. If you don't like it, we can always go back to the dangler type balloon tube. So there's really nothing lost there to try. We've had other patients where we say, we'll try it, and they love it. It still works, and that's great. Then they can go ahead and keep using that tube. There is a jejunal tube, a dedicated low profile jejunal tube pictured there also. Again, that one you could, that's actually a low profile TGJ, so you could vent and feed from that tube. That tube again, same as the other TGJ, it's just that it's a low profile. So, and we do have dedicated jejunal low profile. So technically any tube that you have, it should come in a low profile type. Again, just really depends on the size And here at Mayo, we do, if it's somebody that's asking, we do make sure that one of the nurses will see them before they get to replace it and just make sure that they can attach. Some patients, if they have had a lot of neck surgeries and it's very difficult to bend the neck down, it's hard to then get down in your stomach and attach this and hook up and then hook up again. So even though that it feels like it'd be a great idea, sometimes it just doesn't work the best for the patient. Technically, we hear a lot that it's if a patient is active, they like to do a lot, they're very busy, they need a low profile. In my 13 years now of experience, I have never seen somebody not be able to do what they need to do with a dangler tube. If it's taken care of properly, if it's secured, there's no reason you can't be active and do everything. So the argument that the low profile is what you need so that you can live an active life, you could be active, I don't find true. I think you can do that with any of the tubes, which is nice because some people need each of the different types. Picture of a low profile on a little tummy there. We don't have one in adults. Questions, comments, concerns?
Thanks, Sarah. We appreciate your talk, as always, great. I think there was a comment that said, some use PEG tube for venting and draining for quality of life. If change all to ENFit with their small openings, it will make draining very difficult, thus reducing quality of life. I don't know if you want to comment on that.
Sure. And so that's a good point. ENFit is here to stay. It's a big question. We actually researched 2 or 3 years ago now, went through all the tubes, tried to hook them up to see what feedings would work. Can we vent with them? You can vent with ENFit. So what I just showed you with the low profile, that doesn't change. ENFit really hasn't changed at all. Where did I set that to? I just lost my low profile. The low profile tube doesn't change. The adapter that we put in there, the end changes. So now that you have ENFit ends, you have the ENFit ends on this end. This end hasn't changed. So ENFit doesn't change anything to do with how we hook up for like the low profile. So the low profile tubes themselves have stayed the same. They don't change with ENFit. And so it's just the actual end. So if you can't vent from a low profile because of how small this hole is, ENFit's not going to matter. Our tubes are all ENFit now here at Mayo. We have people that have these tubes and have no problem venting. We had some issues in the beginning just trying to figure out how to hook up, what to hook up, but have not really. Our patients usually are still able to vent. We have very few anymore that will come and say, I can't vent. It's because of the ENFit. You can still hook up to a bag. You can still do all that. The hole is a little bit smaller than it was on the legacy tubes, as we call them. However, we found that with, excuse me, a couple of our patients that couldn't vent well, they still wanted to be able to eat everything and still be able to vent, eat for pleasure. Totally understand that. However, we do have venting guidelines that we use. And so some of those foods, if they're not going to break down, just aren't going to break down and flow through the tube, regardless if it's ENFit or not. Just FYI on that, we have heard there will be no legacy tubes manufactured after July in the United States. So for everybody that does not like ENFit, it's here to stay.
Yeah. And on that note, we do have two things. My colleague Lisa Metzger put in the chat that we do have a Enteral Connectors Feedback 2021 survey. So if you are on a feeding tube, help care for someone on a feeding tube, or a clinician caring for an adult or child on a feeding tube, please take a few minutes to take that survey. We also have a kind of a save the date, May 7th, 12:30 to 3:30 p.m. Eastern Standard Times, a virtually for an Ole Summit on Enteral Connectors. It's an opportunity for stakeholders to share, listen, and learn. Watch your email or the Oley website for registration information coming soon. And just so everyone knows that the venting and NFIT will both be topics that they will be in the summit next Friday. And with that, I think there's just a few more questions. I think we have we have a few more minutes. How often on average?
Oh, sorry,
go
just
ahead, Sarah.
with Lisa's comment, AMT has announced that they will still be producing legacy tubes. That I'm just coming with the knowledge that our dietitians have been told. And yes, if AMT is still going to manufacture, that's great. Our concern is that you need to stay in your area if you're going to go with one of those tubes, because not all the DMEs are going to carry all the supplies. Like here at Mayo, we won't keep both legacy and infit tubes. We don't have legacy anymore. So I get the concern to want to have legacy. Just keep that in mind that, you know, the supplies are going to run low to be able to switch those, to be able to go somewhere else and have a tube replaced. It's going to be harder and harder to get the legacy tubes, but
and
I'm glad that
Sarah, this is Joan, and I'm inviting you to the summit on Friday. I hope you can reserve from 11:30 to 2:30.
Next Friday?
Yes, yes.
Oh, I will certainly look at it.
We're going to keep you close and connected.
Oh,
okay.
We certainly, I told Sarah once she's in.
Yeah, I will certainly see if I can. I know there was a question
there
that I'd
are
gotten.
A few more.
Okay.
And there's a few more in here, Sarah. Actually, there's a bunch of them, so we'll see how many we can get to. How often on average does a PEG tube need changing?
Good question. For our balloon tubes, we go with the manufacturer's recommendations of every 3 to 5 months. Bumper tubes, we say 8 to 12. One reason on that with the bumper tubes is GI will traction pull a bumper tube up to 1 year old. So instead of having to have a procedure, have sedation, and actually have a full procedure, GI will actually pop the tube out and traction remove it. Over a year, they will not do that. So then it's another procedure. So for any of our patients that have ALS, that have a lot of respiratory issues, and the sedation gets to be a tricky part, that gets harder and harder. Our locking loop catheters are 12 French, and we do replace those or recommend replacement every 6 months. This is Mayo Clinic's guidelines, and we are a little reserved. However, a lot of our patients will come and say, you know, my doc at home said, leave that tube in until it's a problem. That's fine. However, the problems tend to be Friday evenings, Saturday afternoons, can't get in with the surgeon until the following week, 2 weeks later. So for us, we just like to, because we have so many patients, we like to be proactive and just get those tubes replaced versus waiting until there's a problem. So that's my comment on that one. We get a lot of feedback that our doc says it doesn't need to be changed. And it's like, and it probably doesn't, but when it clogs or falls out and there's a problem, we just like to try to prevent the problems here.
Yeah, gotcha. Oh, wow. We have a lot of questions and we only have a couple more minutes. We'll try to get one more in, and then if it's okay, I will pass these questions on to Sarah. She can answer them, and I will put them on the website afterwards. So
yes, and I know there was a question from Lou, and I will send you some stuff for him.
Okay, wonderful. Another question is, does Sarah have a preference for specific surgical TGJ, dangler, AMT, BARD, et cetera, especially for a patient that needs to easily and adequately drain and vent the stomach?
My preference, honestly, is the actual TGJ balloon. Both tubes are good, and it is nice to have that bumper place with the jejunal extension. However, we have tended to see that jejunal extension flips more or clogs more because it is a smaller tube, and then it's being put through the pegging going into the jejunum. The actual TGJ tube is created to do both of those things. So the generally GI will use a 18 or 20. Well, they only come 18 or 22. I know they come smaller, but GI tends to place a little bit bigger. So with that tube, they can do both. We have a nice tube. These, yes, they can flip, but they tend to flip less often, and they just seem to last their full 3 to 5 months. Whereas the jejunal extension, we tend to have to replace at 6 weeks, 8 weeks because it's clogged or it's flipped. Again, another procedure for the patient. So in my mind, this one is the one I would prefer. For us here, it really depends on GI proceduralist has the final say.
Great. Well, we have a whole bunch of questions that came in, so perhaps this may be something we could spill over into a webinar at some point. But unfortunately, we have to move on to our sponsor coordinated session. Sarah, thank you so much. You were
You're welcome.
so fantastic.
Thank you for having me.
Thank you for sharing your expertise. I'm sure we'll be pulling you into many more Oley meetings in the future.
And I would be happy. She can send me all the questions.
Wonderful.
I will do my best to get some answers back to you. Just know all my recommendations are Mayo Clinic recommendations.
Fantastic. Thank you so much, Sarah.
Thank you, guys.